Developing innovative approaches to deal with a variety of issues facing healthcare takes input from a variety of sources. The Innovation Academic Incubator at OSF HealthCare works to move the process along.
If I may just mention in particular something that I find truly transformational. I knew we had something special when I saw pediatric cardiovascular surgeons coming into the virtual reality lab at the Jump Building to actually put on VR goggles and look at a child's heart before they went into the operating room. You can imagine how busy these clinicians are. To take that time out and put that investment into this particular technology was extremely meaningful. And Dr. Bramlett and others on the team have been able to generate transformational technology that exists only at OSF. It is making a key difference in our most vulnerable patients every single day, and it involves every aspect of our care team.
That's Dr. John Vozenilek, Vice President and Chief Medical Officer for Innovation and Digital Health at OSF. And I'm Shelli Dankoff, your host for OSF HealthCare Accelerated. We appreciate you tuning in and remind you to be sure to subscribe, rate, and review wherever you get your podcast. IAI, 3 letters that can stand for any number of things. For OSF HealthCare, it stands for Innovation Academic Incubator, which cultivates partnerships between OSF clinicians and academic institutions to create novel healthcare solutions. They are 4 programs that have funded 237 research projects, resulting in 140 publications and 12 patents. Here to talk about the IAI and more are Dr. John Vozenilek, the Vice President and Chief Medical Officer for Innovation and Digital Health at OSF HealthCare, and Dr. Mike Cruz, the Chief Operating Officer for OSF HealthCare. Thank you both for being with us. Dr. Voz, I'm going to start with you. What exactly is the IAI and who participates in it?
Well, if you consider all of the different types of mission partners that come to work every day and they work to the betterment of patient care outcomes, you have to realize that they come from a variety of backgrounds and training, a variety of disciplines. And those disciplines are really brought forward through training and education that are received at our universities, and not the least of which are University of Illinois, University of Illinois Chicago, the Bradley University, and the Illinois State University. And we actually draw quite a few mission partners from those elements. But consider what we could do for innovation if we could really tap into those talented people, the professors, the trainees, the graduate students, all the people who are designing and developing our future, and draw them closer to us, and in particular to draw them closer to us to solve the problems that we have in patient care delivery systems and patient care outcomes. It's really the marriage of a solid clinical platform with a solid academic platform to make things come to life through innovation.
I imagine from their perspective, a lot of engineering types and those kind of things, they probably never thought they were going to end up in healthcare. And all of a sudden now it's, wait, what do you mean I can do that? Or they tell people they're working on healthcare. That must be interesting for them.
I think it's fascinating for any professor or student to consider what's happening in the real life circumstance. It really creates a relevancy to the training that they're receiving in the day, right? But it's really important, the thing I said about like the diversity of talented individuals who come together in certain ways to make our care safer, more reliable, higher quality, and to really advance patient care outcomes. It goes well beyond strictly the house of medicine or the house of nursing to deliver that. It really requires biomedical engineering, device creation, software, security, all kinds of things that come from our broadest university partners.
Now, these partnerships didn't just happen. There wasn't just some magic dust sprinkled and all of a sudden it happened. There's a lot of hard work. How did they develop and come about?
Well, this is the confluence, some would say the providential influence that we have here in our community. So the first offering came through a vision to bring engineering and our clinical problems together, and a particular philanthropist and the DeSoma Family Foundation really seeded a relationship between the University of Illinois and OSF. And the idea of creating a structure that allowed both the academic partner and the OSF partner to come together in a unique way to advance patient care outcomes through innovation, well, gosh, the benefit of philanthropy in the moment where we needed each other, again, is really a true boon to our mission.
Dr. Cruz, I will turn to you. When you look at the OSF Healthcare Ministry as a whole, hospitals, facilities, everything that's involved, how does the IAI and those partnerships fit into the whole ecosystem, and why is it so important?
Yeah, no, it's a great question, and the get is actually really large. It's very infrequent in the house of medicine and in healthcare in general, where there's a forcing function, if you will, in a comfortable fashion, where we can combine the true academics and the research and the PhD and the postdoc types who do that for a living alongside people who are clinicians who take care of patients for a living. So that point of contact, collision, colliding, if you will, created by these programs has really allowed us to solve for some problems that have been around for a long time with some novel solutions that, unless those two minds are together, one clearly understanding the clinical aspect and one clearly understanding the ergonomics, the workflow, the design, the queuing theory, and bringing all that infrastructure. And it could be as complex as molecular and immunologic too, but sometimes it's not even that complex. We're combining an engineer with a doctor, a clinical informaticist with a nurse, a pharmacist with a computer, analytics folks who do that for a living.
So I'll turn back to you, Dr. Voz. How does a researcher get involved in this? What's the process? Do they just say, hey, I have this great idea, how about we try this? I mean, that sounds pretty simple, but you're probably going to say, sure, why not? But what is the process, and how does it all work and get rolling?
Really, in the fundamentals here, it is about the fact that in our ministry, we have individuals that are operationally executing every day, and they encounter certain struggles. They identify through an innovation process the key problem to solve and the need statement that needs to be addressed. And on the other side of this, we have massive technologies that are being developed every day by people who are investigating and pushing the edge of science and technology in every aspect. And so when you can reveal these two together, then you have essentially the starting point. But what really makes it happen is relationship. And so we spend a lot of time trying to develop the key relationships that make a difference between our OSF clinicians and the academics. This may be an engineer. It could be a person who's teaching a master's program in social work. It could be someone who's teaching about data science. Bringing those two together and to show what that problem is and the need in a certain way. And I have to say, I think the key element of this program, which is different from many other research funding initiatives, and particularly ones that live in the academic space, we're not looking for bench research. We're looking for something that translates very quickly to the bedside, makes a more immediate impact. And while it's very appropriate for our academic institutions to invest in long-term goals and to develop technologies over decades, at point of care, we want some more immediate outcomes. And so bringing those two together and describing that immediacy and that relevance makes magic happen. And then we throw a lot of parties. So literally, we put on symposia, we put on networking events, we put on workshops, we bring people together, they get to know each other. We bring snacks, and they loosen up, and they talk about exactly what they're passionate about. And when you can bring those two types of partners together in that moment, you really have something.
Absolutely. So if somebody is listening to this and they're like, wow, that sounds really cool, how do I get involved? Do they wait to hear about that? Can they go online through the Innovation website and be like, hey, there's that, I can apply? Is that exist? And I know jump arches and all of those type of things. Tell me about that.
Right. Well, firstly, there are 4 different mechanisms, right? So the jump arches mechanism is a mechanism that is an Urbana-based, University of Illinois, Urbana-Champaign. The Community Health Advocacy Initiative is with UIC. The Innovation for Health is with Bradley University, and Connected Communities Innovation is with ISU. And each of these have different offerings. They submit to the web and to our network and to our mailing list and through social media a call for proposals. And those initiatives come out on a regular basis, oftentimes in fall and spring, and those initiatives offer funding for these programs that are brought forth by both a mission partner and an academician. And so, yes, the answer is quickly yes. A lot of social media presence, a mailing list that's particular, the website information, and a regular sequence of calls for proposals to really engage both teams.
So the information is out there to find. And Dr. Cruz, we talked about over 200 projects, research projects already funded. Are there some that we're working on now, just so people get a sense of what types of things we're talking about? What projects are out there right now going on?
Well, yeah, so there's multiple projects. Some have already come to fruition. That might be as simple as how do you standardize a crash cart across the healthcare system, which seems like fairly intuitive for clinicians who are in code situations or in arrest situations in-house, and yet across a large system, each floor might have one or two of these crash carts. And there's adult crash carts and there's pediatric crash carts, and the pharmaceuticals in those carts are in a specific drawer and have different doses depending if it's an adult or a child. And those protocols are pretty standardized. Well, how do you standardize that across the system? So just an example of something that might seem as mundane as a crash cart is critically important because seconds matter in minutes during a resuscitation. And when people fumble, people meaning clinicians, doctors, pharmacists, and nurses, and fellows or residents and students, when they fumble, you lose that time. And you also have the perception that, do you know what you're doing? If you can't find the medicine or the device in the right drawer. And then we have staff who go from hospital to hospital. So if it's not standardized, it's a little rodeo, depending on what hospital you go to, or emergency department, or ICU you go to. So in short order, there's something as simple as that. And then how do you teach and simulate and make it fun through gamification? Well, doctors and nurses aren't gamifiers in nature, right? And so maybe we have to partner with a Bradley or an ICU or U of I and say, hey, you know what, you're engineers and you work in software and you do gamification as part of your science. And so how do you put that together so that it's available for the clinicians to say, it's not just a module or check boxes on a page and you're checked off and you're ready to go. So think about that with tons of different procedures that are done day in and day out. So once again, the training, the education, other things, Clinipane is something that's more recently designed. How do we make the workflow for the clinicians easier without being interruptive, without creating more noise? You know, EMR has a lot of value, electronic medical record, but in itself is just a way to capture information and data. If it makes it clunky and very difficult, that actually doesn't help in a lot of ways. Great, it's captured someplace and maybe you can go query it, but for day in and day out of operations. So how do I make my workflow for taking care of somebody with COPD or chronic obstructive lung disease more efficient in grabbing the data, grabbing what we know about the patient, and putting it in a user-friendly fashion, and what are the best protocols for use for somebody who's that ill? And we put it in a fashion so that the clinicians can actually view it at the same time they're doing their regular work. So they can ignore it, they can turn it off, or they can review it as they're doing their work. It's not making decisions for doctors. This is not a cognitive synthesis. It's not going out on the internet and say, how do I take care of this patient? It just brings information in a very cogent fashion. It's all there. It's just hard when you had a medical record that was 4 inches thick and you're having to do that for here's the echo and here's the chest x-ray and here's the CT scan and here's their pulmonary function tests to find out what's the best. Now we can use the EMR and leverage it with some AI technology, i.e. like Clinipane, and the doctors who actually work in that environment, not only the data doctors who understand the data part, but also the clinician doctors who actually take care of those patients together. This is the mixing, so the secret sauce, and then they come up with that kind of design. So think about that for pharmacists and how they do their work, or nurses, or an occupational or physical therapist, and how they pull that work together. So not just about doctors, so we see a lot of that value in multiple clinical spheres.
I hear the excitement in both of your voices as you're talking about some of this. You are both physicians by training, emergency medicine. And so this is a differentiator for OSF, isn't it? Why does this excite you moving forward? Because at the end of all of your sentences, I hear it's what's better for the patients. Is that what excites you the most?
Yeah, John had touched on that already. He mentioned outcomes. At the end of the day, a lot of this is really great and is really awesome, but until we can actually measure the outcomes in this, right? Until we can measure in some fashion that the 3D or 4D modeling for how we take care of a congenital heart child, whose heart looks very different from any other child's heart malformation, or a child's spine, or a gynecologic tumor in a woman, every single one of those is different. Well, now we're already doing ultrasounds and CTs and MRs. What a great opportunity to pull that together so that when the surgeons prep for surgery, they have a much better idea of what they're getting into. And how does that translate? Well, how I approach, what's the equipment I need, how much blood am I going to need because I pre-planned, and how much time in the OR. We talk about times, length of stay in days, or even in hours. In the OR, it's in minutes. We count OR by minutes. That's how expensive it is to use those resources in the OR. So all those things are going to impact outcomes. Yes, patient outcomes, because we planned about you or myself or family. But really, it also means there are other outcomes, which is value to the organization, to the patient and payers, and also utilization of blood. That's another resource that's not only is expensive, hard to get, and so are we really optimizing and doing what we're supposed to be doing and taking care of those resources?
It is, as you say, it's exciting, and the patient care piece of this, being at the bleeding edge, being at the sharp end, if you will, that's what's important, 100%. What's also very exciting, and what excites me personally, is when I get to see the dynamics between the teams. So it would be regular to think that professors in academic environments are constantly exploring and testing new ideas and driving hypothesis-driven inquiry forward and getting results. When we bring those types of cultural differences to our mission partners, whether they're a nurse at the bedside or a pediatric cardiovascular surgeon who's providing transformative surgical care, or somebody who's working in our data science, and we bring that innovation culture in and we fund it and seed it and grow it and we nurture it. Wow, we've really lifted OSF as a healthcare system up as well through this type of mechanism. I'm really excited about that. And the other feature that I'm super excited about is our ability to recruit. So as I mentioned, we draw from these major universities in our areas to our mission, like as future employees. And we get to know them. We get to see how they think. They get to be part of our culture. We get to invite them in a special way to be a part of that culture, which is all about the best patient care possible. And, we really attract some of the best and brightest from our state. It's a true advantage, and it's a different type of outcome that comes from the fruit of this systematic approach that we put in motion.
Are partnerships such as this important to the future of healthcare?
It's amazingly important, in my opinion. And I'll also say that, right here in our backyard, we have the University of Illinois College of Medicine at Peoria, and they provide wonderful clinical care, in particular in pediatrics and adult hospital medicine and other features, infectious disease. And they're in our midst as well. And they're a close academic partner and have been so for many, many years, many decades. And those individuals also bring a certain type of research and vitality. And it's probably a little more typical to consider that medical schools are of interest to healthcare systems because we can draw those clinicians into practice in the future. And again, think about what it's like when you bring a team of medical students and you bring them in close proximity to a team of engineers, and then they get to design their future. Like, it is truly an amazing moment to watch. And that's what really, it gets me very excited when I think about it.
Any final words before we wrap this up that you think is important for people to know about either how we got here, all the cool ideas that may be spinning out there, and how to get involved, or anything else that you think is important?
I just make one comment. We haven't brought up the word like translational science or research, and essentially that's kind of what we're talking about. John specifically talked about the importance of the lab, whether the wet lab, where the PhDs who are critically important to be pushing science at a molecular level or physical level or sociologic level through their biologies and whatnot. And then we have this healthcare system, but really what we need to do is this speed to outcome. And that's where this is really translational, because things have to go pretty quickly from a lab to an outcome. Otherwise, and we can wait 5 and 10 and 20 years, but things are happening too quickly, and the expectation for better, faster, or best is too critical for healthcare. So the speed with which he spoke to a little bit is really an important part about translation, whether it's in oncology or pediatrics or adult or surgical or in the office space with ambient listening. How do we make clinicians, more value, create more value for them? Yes, for the patient, but also for the clinicians who do that work and are inundated with the medical record and the chart. Well, if I can do ambient listening and create a record that's 99% accurate, things like that just really create a lot of value. It's not because the doctors have to see more patients, like twice as many because we made you twice as efficient. The point is now they get to spend that time with what they had before, prior to the EMR, which is you had a piece of paper and you wrote on it. You might not have been able to read it. You couldn't query it. And from a data standpoint, it was not very helpful. So how do we catch that up to say, yeah, the EMR can provide this, but how do we make the clinicians as efficient in front of the patients and let them do the interacting? And then all the analytics involved in that is going to have to be baked in. So I think this translation from the computer to the patient, or from the wet lab through the doctor, nurse, or pharmacist to the patient is where the secret sauce is. And that's really translational.
That's the key. And we want to make this be the most wonderful investment with a most wonderful return on investment that we may. And here I am talking about the talented individuals who provide excellent service at bedside and the patient care outcomes. I'm also talking about the ability to nurture this program in a particular way. We've been blessed with wonderful gifts from philanthropy that actually make this happen. And the OSF Foundation has matched their financial resources with many philanthropists in our community that have brought their funds, their treasure to this enterprise, including the DeSoma Family Foundation as a lead. And then the academic partner brings their resources as well. So it's really a matching program. And to make good on this investment, we spend a tremendous amount of time. We have mission partners who are dedicated to take our clinicians by the hand and show them how to do this type of hypothesis-driven transformational work. We have people who can help with the budgets. We have a ton of investment in how to make this sing, because we think it's just that important. And not the least of which, our social media presence, our website, our listservs that people can get involved with so that they can see what's there. I think fundamentally in every bedside clinician, there's a desire to deliver that excellent care each and every time. And every once in a while, we get a little frustrated, we get a little confounded, and we want to problem solve. This is a tool for that. And we've seen some of the most phenomenal innovations come from our nursing staff who are at the bedside every day providing that excellent care. So nurses are involved, doctors are involved, data scientists are involved. Every aspect is brought to the table here. And it's really like nourishing this environment that's key. So we really want to make good on all this potential, because it really does make a difference in patient care. If I may just mention in particular something that I find truly transformational, and at the bedside that Dr. Cruz mentioned, which is I knew we had something special when I saw pediatric cardiovascular surgeons coming into the virtual reality lab at the Jump building to actually put on VR goggles and look at a child's heart before they went into the operating room. You can imagine how busy these clinicians are. To take that time out and put that investment into this particular technology was extremely meaningful. And Dr. Bramlett and others on the team have been able to generate transformational technology that exists only at OSF. And there are new announcements that are coming out soon to describe that technology, so I won't steal that thunder. But I will say, it is making a key difference in our most vulnerable patients every single day, and it involves every aspect of our care team.
And on that, Dr. John Vozenilek, Dr. Mike Cruz, thank you so much for the fascinating conversation, and it puts that out into the stratosphere where everybody, if you want to get involved, we need the ideas. We'll take the ideas. You know where to find us. So we thank you for watching as well and remind you that you can find all of our OSF Healthcare Accelerated podcasts by going to osfhealthcare.org/accelerated.